extraction, stripping, and sequential selective enamel stripping, transverse expansion, and sagittal expansion can be done. Space supervision is that when the patient presents with a moderate crowding, we'll have to keep in mind about the leeway space, which can be utilized for correcting the crowding. So preserving this space for correction of crowding is also essential. And management of incisor crowding, depending on the amount of crowding which is present, we can decide on whether we have to sequentially strip the primary teeth, preserve the E-space, and a combination approach can also be employed. Now for preservation of E-space, for maxillary arch we can give transparatal arch, and for mandible we can as well give lower lingual holding arch. Now these are other methods of correcting crowding at a very early age when expansion can be brought about to bring more space and more room for the teeth to erupt. Yes, we can employ serial extractions too. We have various methods of serial extraction. We can employ whichever is suitable for the clinical scenario of the patient presenting with. Moving on to oral habits, we are all aware about various oral habits. We have thumb sucking, lip biting, mouthing. Whenever the patient presents with certain oral habits, we'll have to see what is the effect it has already caused, and then how are we going to actually prevent any further damage. So here comes the interceptive and the preventive part of orthodontics. As far as thumb sucking and finger sucking is concerned, we have various dental and skeletal effects. So until say patient has turned 4 or 5 years, we can wait for the malocclusion. I mean, we can wait for the habit to wean by itself, or else by then, even if the patient continues even further, then there is going to be evident dental and skeletal effects. We have increased overjet, anterior open bite, interdental spacing can appear. A patient might have an high arched palate. As far as skeletal effects are concerned, patient might have a counterclockwise rotation of the maxilla, clockwise rotation of the mandible, and increased mandibular steepness. All this can be an effect of thumb sucking. So it is important for us to educate the patient regarding what all effects could occur because of thumb sucking and curtail the habit at the right age. Now, age of intervention, as I said earlier, it is like we have to wait until say 4 or 5 years and then progress with the intervention of the habit. Treatment approaches, of course, it includes psychoanalytical methods, behavioral modification, that is reminder therapy, and use of orthodontic appliance like you have crib, combination method, and also the palatal crib. As far as tongue thrust is concerned, here actually I want to mention that whenever the patient is having a tongue thrust or an anterior open bite, we'll have to keep in mind always when the patient presents with an anterior open bite, you have to think in terms of whether the patient is having a large tongue. One, is the position of the tongue correct? All these things have to be estimated when the patient presents with an anterior open bite. So when you have identified that tongue is the culprit, then obviously we'll have to see on how to curtail the tongue from reaching in between the interdental space between the upper and the lower anteriors. So oral habits training is an exercise that taught by qualified speech therapist also can be employed, and re-educate the muscles associated with swallowing by changing the swallowing pattern. As far as mouth breathing is concerned, see, there are many parents who report to us speaking about the patient actually opens his or her mouth during the night time and sleep. So one thing which we'll have to keep in mind is we are all aware about the Cayman's growth curve, where the lymphoid organ growth happens to attain its 200% growth at the puberty. So I would suggest that we have to wait until the lymphoid aggregation, that is the lymphoid aggregation shrinks. That is after the patient attains puberty, there is going to be regression of the growth of the lymphoid. So thereafter the airflow actually improves for certain patients. So before any intervention for the airway, we will have to ideally wait until the patient attains puberty and then take the call regarding the mouth breathing habit is my suggestion. So whenever the patient is having mouth breathing, obviously we have to see other etiological factors, like if there is any nasal septal deviation or nasal polyp or any other problems of that sort. And also in many patients, expansion has actually helped many patients for relieving from obstructive sleep apnea. The reason being the position of the tongue improves once the expansion is achieved. That is, when the patient is unable to place that tongue at a more towards the more on the palate, then obviously there is going to be obstruction in there is no room for the tongue. The patient is going to place the tongue slightly backwards. Obviously, when you expand, the position of the tongue gradually changes, and thereafter there is an improvement in the breathing. That's what I have experienced in my patients. So all these things are the skeletal and the dental changes, what could occur because of mouth breathing, and how we can go about improving it. Yes, we can employ expansion for these patients. There is going to be good amount of reduction in the airflow resistance, and we also have other oral appliances which will actually move your lower jaw. So generally, mouth breathing patients have a retrographic, that is a smaller mandible. So the position of the tongue is also slightly backward. So in these patients, when we are giving an appliance which is going to bring their mandible forward, it is actually going to give more room to the tongue, and the breathing is going to eventually improve. So these kind of appliances, oral appliances, can actually bring your lower jaw forward and improve the airway. And we have already seen about orthodontic teeth, lateral incisor, missing lateral incisor. As far as when we consider for canine substitution in such cases, what we'll have to consider is the patient's profile. See, whenever you see a canine has already erupted in the lateral incisors position, what is the call for you? Like, what are the changes which you'll have to bring about to make it look like a lateral incisor? And what are the changes you're going to do on the neighboring teeth is what is going to matter to us. Now, profile has to be straight for such patients when you're doing a canine substitution, and the patient should not have a high smile line. The reason being, the gingival zenith of the canine is much higher compared to your lateral incisor. Lateral incisor, the gingival zenith is slightly lower, whereas for canine it's slightly higher. So all these things, when the patient is having a high smile line, is going to become more visible to them. So it is better to avoid in such cases to replace, to substitute lateral incisor with a canine. And also the color of the tooth. Canine is slightly more darker shade than that of the lateral incisor, so we'll have to see if the shade is suitable. And they say if you have converted the canine to the lateral incisor, the premolar, the buccal cusp of the premolar has to be built in such a way to simulate a canine. And obviously, when you're again substituting canine for a lateral incisor, the canine bulge which is present on the tooth surface also has to be reduced to make it look like a lateral incisor. All these criteria has to be considered before we substitute a lateral incisor, substitute a canine for a lateral incisor. So these are the methods how we are going to actually replace a lateral incisor if at all it's missing. And as far as supernumerary teeth are concerned, why considering supernumerary teeth is important is it might hinder the permanent teeth eruption at any junction. So having a supernumerary teeth, you will have to educate your patients that if at all you have a supernumerary teeth, you will have to see if the other teeth in the arch have erupted at the correct pace, or is there any interruption in the eruption. So we'll have to instruct them, if at all there is a hindrance, we'll have to extract these particular teeth. And it is very important to early detection of this and proper removal. So one such thing is the mesiodens, which is common to occur, and we'll have to take an IOP to confirm it's a mesiodens, and there is a constant space between the incisors, it's unable to close, so you'll have to consider extracting these mesiodens. And we also have to consider that if there is any multiple supernumerary teeth, we'll have to sort for situations where we'll have to extract teeth which is required for the patient's normal dental occlusion, and extract those which are not required. Moving on to abnormal frenal attachments, we are all aware about the labial frenum. Mostly we are all aware that labial frenum is high frenal attachment, and how we have this Blanche test to check if there is a high frenal attachment, how to go about treating it. So there is two schools of thought, where one school says that once the orthodontic treatment is completed, you go for frenectomy. There is another school says, no, you start off first do the frenectomy, then do the space closure. It depends on what procedure are you going to actually employ in removing the frenum. So if my suggestion would be, if you're going for frenectomy using a scalpel or a normal minor surgical procedure, it is better to do after the orthodontic treatment when the space closure has occurred. The reason being, it can be that when you're using a minor surgical procedure using a scalpel, there could be scar formation wherein it will hinder the further tooth movement, or it might reopen the diastema which you have corrected. And maybe if you're employing a laser method, then it is okay to do it as and when you please. Okay, so this is about labial frenum. Whereas other problem is you might also have, say, a lingual frenum or a tongue tie. And lingual frenum can occur on the labial side also. The patient might be presenting with some recession. You might be wondering, there are no local causes. Why is the patient having recession in the lower ends? There is no trauma from occlusion, but still the patient presents with recession. So you will always have to check for any frenal attachment which is very close to the gingiva. So that is one common reason which we have seen in our practice causing recession. And as far as tongue tie is concerned, whenever you are correcting a patient's crowding, it is important that you actually exercise the tongue tie so that the crowding doesn't return back. So that is a very important step which we usually follow. And other eruption problems, you'll have to see for any systemic reasons why the eruption has not occurred, or there is a primary failure of eruption. If there is any space discrepancy for eruption, all these things needs to be checked. Yes, we also have a lot of systemic reasons like vitamin D deficiency or hypothyroidism. Any syndromic conditions can also cause problems in eruption. Now moving on to skeletal problems, we are all aware that majorly we have two skeletal problems, that is class 2 and class 3 malocclusion, which can occur. Where class 2 malocclusion, we have class 2 division 1 and class 2 division 2. As far as class 2 division 1 is concerned, patient is having an excessive overjet with a class 2 molar and class 2 canine. Thereafter, how we are going to correct it? It depends on actually when patient approaches you. Like say for example, the patient who's having still a growth potential, we'll have to first take a lateral set to check which jaw is at problem, whether it is the maxilla or the mandible. Because most of the time what happens is that the patients are already told that when patient is having a problem, we'll treat the lower jaw. That is, we'll give a functional appliance. But we'll have to see where the problem actually lies, whether it is in the maxilla or in the mandible, and then progress with our treatment. So we have various treatment modalities for class 2 malocclusion. First step would be the patient is in the growing stage to do something called as VTO. I'm sure we're all aware. It's something called as visual treatment objective, where the patient is asked to bring the lower jaw forward and confirm dentally if the patient is having a class 1 canine and a class 1 molar after advancement, and is the patient's profile improving. So this patient might be a good candidate for correction using functional appliance. So usually most commonly the functional appliance which is used is the twin block because of the compliance, because it's a 2-jaw appliance and it is worn 24 hours. So it is more efficient. And the other thing which I was mentioning is to see which jaw is at problem. So when we find out that the upper jaw, that is the maxilla, is at problem, then we'll have to consider using some headgears to restrain the further growth of maxilla. Because if say you're giving a twin block and still the problem is not correcting, then you're treating the wrong jaw. That's the reason why it's not correcting. So you'll have to first do this assessment and then proceed with. Even in headgears, we have various varieties. Like say for example, the patient is having a long face and the patient is a vertical grower. Then obviously we'll have to go for a high pull headgear where it's also going to restrain further extrusion of the molar and also going to pull the upper jaw backward. It's going to restrain further growth of the maxilla. So this way we are actually attending to the problem and allowing the mandible to grow in its normal phase. This is what exactly happens when you employ. So this is the amount of skeletal and dental changes which could occur using headgear. Again, we have cervical pull headgear where you feel the patient's lower facial height is less. You have diagnosed that the problem of the problematic jaw is the maxilla, and you feel the lower facial height is slightly reduced. So in these cases where you feel extrusion of the molars might be helpful. So extrusion and discalization of the molar and the restrainment of the growth of the maxilla is also going to be helpful in such conditions where the patient's lower facial height actually improves. So we have to see patient as a whole and consider what is good for the patient and then employ the treatment modality. Now these are non-compliance appliances which have come forward now. Twin block, apart from twin block, we can also use something called as Herbst appliance. We also have something called as advancing. All these appliances, they are non-compliance appliances which can also be used for patients, which is also much helpful. We can see the improvement of the profile of this patient. Moving on to class 3, as far as class 3 is concerned, whenever a patient walks to you with class 3, it's very important. Say the patient might be as young as 5 or 6 years. class 3 intervention has to be done much earlier than class 2. This is a thumb rule. That is whenever, because when I was a general dentist also, I used to think like whatever treatment we will do it after 12 years. That was my mindset. But as far as class 3 malocclusions are concerned, we consider the class 3 malocclusion, we have to intervene at a very young age. Especially for girls, we'll have to intervene much earlier because their growth completes much faster. The mandibular growth completes much faster. So the intervention has to be done much earlier. So what are the signs which can actually, with which we can say the patient is actually progressing is patient presenting with straight or concave profile. Malar deficiency. This is something which is which can be easily identified that there is maxillary growth is restrained. The malar prominence is missing for the patient. And also in few patients will have scleral show. Increased scleral show is also one sign. And we also have tongue. Position of the tongue also matters for these patients. So generally the position of the tongue is much lower in the floor of the mouth rather than more prominent position. And these are some signs like we see crossbite, developing crossbite, the canine relation, molar relation, all this has to be taken into consideration. So well, as far as treatment timing is concerned, there are various authors have various views about it. Delbert actually he suggested intervention between 5 to 8 years. At the time of initial eruption of the maxillary central incisor is when he suggests, because he felt that probably exhibiting the proper overjet and labial eruption of the incisors is going to actually prevent any further problems like worsen the class 3 profile which can occur. And greater degree of anterior maxillary displacement can be obtained when protraction face mask therapy starts in early or mixed dentition was his view. There are other authors who said that there will be positive characteristics, that is change in the maxilla and maxillary position much changed when the intervention is done much earlier. Now this is another sign, like say for example if we are seeing a class 3 patient, the intervention has to be done between the cervical vertebral staging C1 and CS2. Whereas for class 2 patients it can be done a little later. Later in the sense probably in the next stage also, when a peak pubertal growth is there we can do for class 2 patients, whereas for class 3 patients we can't do because the maxillary growth almost completes by then. So what are the other treatment modalities? We have face mask and rapid maxillary expansion, as I already told, because all class 3 patients mostly they will have a constricted maxilla, and expansion is going to actually help. Expansion and protraction of the maxilla is actually going to help their position. And we also have tandem traction bow and maxillary protractors. These are the various designs of protraction masks which can be used. These are the other combination therapy which can be used, like Frankel 3. All Frankel 3 can be used when the patient is much younger. These kind of myofunctional appliances are much helpful in class 3 patients too. Now this is one case where early treatment of class 3 was done. It was a 10-year follow-up. For this patient, chin cup was given to restrain. They found out the problematic jaw was the mandible, and they had actually employed chin cup for this particular patient. It actually this is end of the interceptive phase. We can see a positive overjet and overbite for this patient, an improvement, drastic improvement in the patient's profile. And this is 2 years after the interceptive phase. This is actually 10 years follow-up. So this is the importance of intervention of a class 3 patient much earlier, how they drastically it changes their profile and their dental well-being. So these are some management of transverse problems which we already discussed. Like we say for giving improvement in the transverse problems, we can always use slow expanders or rapid expanders depending on the patient's problem, whether they require a skeletal expansion or a dental expansion. And also we'll have to consider the patency of the mid-palatal suture, whether it is patent or not. According to the patient's age, we'll have to decide how much of expansion can be achieved. And we also have something called as a transverse appliance, which can be used for correcting anterior crowding. It is generally used in adult patients too. And as far as management of vertical problems, we've already discussed about open bite and how to manage about anterior open bite. Stopping the habit, first curtailing the habit is of much importance. habit control, and achieving a proper lip seal and swallowing exercises, and growth modification can also be done. As far as deep bite is concerned, we have various modalities. When management during early mixed dentition, we can employ anterior bite plane. The function of anterior bite plane is to bring an anterior stop where we allow the posteriors to erupt efficiently. We also have intrusion arches which can be employed in mixed dentition phase. And we also can use utility arches. So I'd like to conclude by saying that any untreated malocclusion can result in variety of problems, like including it could lead to dental caries or periodontal problem or bone loss, or there could be problems in the growth of the patient. It is very essential for us to identify the problem and attend to it much earlier, so that the patient is not put at a risk of getting a surgery done later or spending more time on the second phase of therapy. So early intervention, I would like to stress that early intervention is much important for us as orthodontists and general dentists to have a knowledge of what should be intervened when, and how efficiently we can improve the patient's well-being and psychosocial affective. So that is something which is important. These are my references. This is my department at Satyabama Dental College. These are my PG students. Thank you for coming, guys. And I'm really grateful for IDEA Tiruvallur branch for giving me this wonderful opportunity. I just hope I did some justice. Thank you, Rajsekhar sir, for putting up with me, bearing